On Health Matters Television for Life. Stroke is the fourth leading cause of death in the U.S., yet it can be prevented. Learn how to reduce your risk. Plus, we'll take you inside the Telestroke network. See how this high-tech approach is connecting small towns to stroke care like never before, saving time.
Our goal is always less than an hour.
And lives. It's information everyone needs to know. Right now on Health Matters.
Health Matters is made possible by our viewers, the friends of KSPS, and by Providence Healthcare.
My name is Beth Perez, and I am a registered nurse, and I work at Holy Family Hospital on the labor and delivery unit. I'm about to have my second child, and I chose Providence because I love and trust the people that I work with, and why wouldn't I seek care from people that I love and trust?
I'm Dr. Andrew Boulay, and when my wife had a cardiac arrest, I chose Providence because I knew that everything we needed for her complex care was available, from the emergency room to radiology to the nursing staff to the specialists we needed for her care.
Good evening. I'm your host, Teresa Lukens, and welcome to another season of Health Matters. More than 140,000 people die each year from stroke in the United States, and yet 80% of strokes are preventable. Tonight, we will learn the signs and what to do if a stroke strikes. First, let's meet our panel. Dr. Cynthia Murphy is a neurohospitalist with Providence Healthcare. She is based out of Sacred Heart, where she is the stroke director. Dr. John Ween is a neurologist with Rockwood Neurology Center. Dr. Christopher Zylak is the Director of Interventional Radiology, as well as the Director of Neurointerventional Radiology at Inland Imaging PS. And Dr. Patrice Stevenson is a physiatrist with St. Luke's Rehabilitation Institute. And I want to thank all of you for being here. And tonight, we do welcome your phone calls and emails. It's an excellent opportunity to take advantage of our expert panel. Also tonight, we are live on Facebook as well. Dr. Ween, let's start with the very basics when it comes to stroke. What is a stroke?
Well, there are two kinds of strokes, Teresa. One is a lack of blood flow to a particular part of the brain. That's called an ischemic stroke, usually from a blood clot or a plugged artery somewhere. And the second kind of stroke is too much blood to a particular part of the brain. That's a hemorrhage, usually from a leaking artery, usually caused by hypertension or other conditions. And then there's a third kind of stroke, which is a temporary stroke or transient event. That's a TIA, or transient ischemic attack. That's an ischemic stroke that gets better real quick, but is a warning sign that something's going on and that attention needs to be paid to what your risk factors are and particular causes that you can treat and prevent a real stroke.
Mm-hmm. Are any of those more common than another?
The most common cause of stroke is a blood clot plugging up an artery causing a large ischemic stroke. That's the most common event that you have. The small strokes from tiny little arteries being plugged in the brain are probably pretty common as well, but they tend to be silent actually. And so they're detected more coincidentally when you come in for other reasons.
Mm-hmm. Dr. Murphy, why is it that we talk a lot about heart conditions and stroke in the same breath? How are they connected?
Well, I think the disease, the mechanism of disease is very similar. I think, you know, cardiology as a field has been very forward in terms of prevention, and we've learned a lot from cardiology from a neurovascular sense. You know, looking at what a heart attack is versus what a stroke is, how to prevent, how to manage, have all kind of been hand in hand. I think we've learned a lot from cards.
So there is that connection basically on the preventative side.
Absolutely. Well, I mean, cardiovascular disease is one of the 5 risk factors for stroke: high blood pressure, diabetes, high cholesterol, smoking, and heart disease. So, you know, a lot of our medications are tailored for both types of disease processes.
Mm-hmm. And Dr. Zylak, talk about your role as an interventional radiologist and what that means when we're talking about strokes.
Yeah, I love my job. First of all, it's a very exciting part of my life, and it's the great thing for me is that all of this work that's grassroots, telestroke, prevention, all of these things that you're talking about basically create a funnel to get the patient to me when they're having an acute stroke. And my job in those situations is to open up a plugged artery in time to save the brain function to prevent the patient from having a major stroke.
Mm-hmm. And quite often that happens very quickly, because when they're in your office or at your facility at Inland Imaging, you're seeing what's going on.
You know, all of these patients are come in through the emergency room, actually at Sacred Heart Hospital, or through this telestroke network that you're going to learn more about and we'll talk more about today. And so all of these patients are seen and cared for by emergency personnel to start and end up at the emergency room at Sacred Heart, and then directly from there, after imaging and evaluation by Cynthia and her team for their clinical aspects to see that they are actually having a stroke, because there's many other conditions that can seem like they're a stroke or not a stroke, and that's really kind of the confusing part of getting patients in quickly, because often the patient themselves isn't able to indicate to anyone they're having a stroke because the stroke is keeping them from being able to speak, or the stroke is keeping them from being able to move. And these are kinds of the things that I always say when we're talking about the cardiology field, why the cardiologists are ahead of us in their work, is that when the heart has blood stopping to it, it hurts, and patients have excruciating chest pain, so they're immediately alerted and understand that, wow, something terrible is happening to me. But when they're having a stroke, a lot of times, you know, unfortunately, patients don't come in, and we'll ask them, you know, why didn't you come in? They say, well, you know, I thought I just slept on my shoulder funny, or I thought if I went back to bed I'd feel better, or I just didn't feel well, I felt nauseated and just didn't feel good. But the brain isn't actually hurting when you have a stroke, and I wish it would, because if it did, we'd be able to treat a lot more patients more quickly.
And that's why patients are so hesitant to go to the emergency room.
Yeah,
they don't realize it's happening.
I think a big part of this is education and patients understanding not only what the warning signs are and what those things can be, and why it's so important to then seek immediate care for these kinds of conditions. And when they come up, we can really do some amazing things if we're given the opportunity to do so.
Dr. Stevenson, I want to bring you in on the conversation here. You actually see stroke patients after the fact at St. Luke's.
Right, so when prevention didn't work or immediate care didn't work to stop the stroke, we see them there to take care of the residual deficits from stroke.
Talk a little about that process.
Well, they usually will come to a place like St. Luke's maybe in the first week after a stroke, or longer if they had complications. And I always tell patients first that there are different strokes for different folks, which most people can relate to that phrase, but they have in their mind maybe what they've seen as somebody having a stroke before, and if that doesn't fit with what their body is doing, you know, it's kind of hard for them to relate to all that. So we really are looking at their medical background and what type of stroke they had, where in the brain it was, which can predict what types of problems we're going to see.
And this comes in sort of as a team approach, because you need a lot of people looking at different things when it comes to post-stroke care.
Right, so we have the physiatrist or the physician, and we're managing their medical aspect and secondary stroke prevention, and then we have rehabilitation nurses, physical therapists, occupational therapists, speech therapists, recreation therapists, our rehab psychologists, social workers, case managers, and a whole, just a bunch of other folks that are all trying to work to get them better and out back to their life.
Let's talk about the signs and the symptoms, because they can be all over the board. Dr. Zyla talked about a few of them. It's difficult because, again, different strokes for different folks, as Dr. Stevenson said. So what are we watching for? What do we need to be keenly in tune with?
Well, I think the most important thing to realize, number one, is it affects a particular part of the brain. And so you see deficits or lack of function on a particular part of the body. We like to use the F.A.S.T algorithm, F.A.S.T, just as our teaching tool. If you have a facial droop, part of your face is droopy. If your speech is slurred, if your arm is weak, if you're staggering, you know, things that are sudden and they're affecting one part of the body, not the other, you got to call 911 right away. And like Chris was saying, strokes aren't painful usually, heart attacks are. In addition to that, strokes mess with your mind, literally. And so you're not aware of your deficits. Sometimes you can't communicate your deficits. Sometimes you don't think that there's even anything going on at all, and you'll resist going to the hospital. And so it's really important that not just the patient, though you don't know you're going to be a patient until you are one, but that families also understand this. And if they have risk factors like the high blood pressure and the diabetes and the heart disease and the smoking and so forth, that the families are clued into this so that they say, no, you're going to the hospital and you're going now. I'm calling 911. And it's really critical to understand the importance of 911, because you get seen quicker if you come in on a gurney than if you walk in, or if your family wheels you in a wheelchair. And that's just human nature, that if you come in on a gurney with its sirens and the lights and everything, everything's more acute. So don't drive in. Don't call your doctor. don't call your family member. Call 911 and come in an ambulance right away.
People don't want to be alarmists, though.
Well, you're better to be an alarmist than have a stroke. So you're better safe than sorry.
So let's talk about some of the causes, what we can't control, what we can control, Dr. Murphy.
Well, I mean, there's modifiable risk factors, just we mentioned, heart disease, diabetes, hypertension, smoking are all the big 5 risk factors. As we get older, age becomes a risk factor that is non-modifiable. We can't do much about it. Atrial fibrillation becomes a risk factor. Where they've found associations with sleep apnea in terms of stroke risk reduction. Part of the process of when a patient, either with John or myself, is it's the acute management of stroke, identifying the cause of it, and then prevention and recovery all in the same package. And it's sort of a multifaceted type team approach that it happens at the hospital as soon as they hit the trauma room. Whether does a patient have high cholesterol? Well, they need to be put on a statin. I know a lot of people don't like statins, but it is showing some good risk reduction of stroke. Do they need aspirin or antiplatelet therapy, which helps with also lowering risk factors? So we're sort of doing that as part of the process of the admission when that first initial presentation.
Because things have to move fast.
The acuity is a big thing, and you really do. No one wants to be an alarmist, but you don't want to miss it either. And so, and John and I will be, I think we're the first ones on the scene, the first ones in the trauma room. We're looking for weakness one side or the other, numbness, tingling. We're looking for any focal neurologic deficits. We're taking them to the CAT scanner. We're looking for CT angio. We're looking for clot, and then I'm on the phone with Dr. Zylak and saying, okay, look, we need you here. And we're trying to see if there's 2 options of treatment. One's TPA, tissue plasminogen alteplase. It's a clot-busting med we give to stroke patients, and that's within a 3 to 4.5 hour window. And so we're treating as fast as we can to get that medication in. Greatest benefits within 60 to 90 minutes, and we want to then move on to interventional. So all of this is happening while the patient's just coming into the CAT scanner. I'm on the phone with the interventionalist. He's looking at the imaging, and we're deciding whether to go on further with interventional. It's an exciting process, but it's something that's changed. So it's brought so much recovery to stroke. It's just been an exciting time to be. And I'm the same way. I love my job. I love going to work because you're in that trauma room. You're trying to get everything done. But the real work will begin with Dr. Stevenson down in St. Luke's. Recovery starts as soon as we hit the door, but really upon discharge is really when the real work begins.
And some of the treatments are surgical as well. We talked about the clot-busting drugs, but there are procedures that can be done surgically?
Yeah, so the FDA-approved therapy was initially, and still is and remains, first-line therapy is IV medication to try and dissolve the blood clot. The truth of the matter is that works very well for small blood clots, and it doesn't work well at all for large blood clots. And so every single patient that I treat has a large blood clot that didn't get dissolved by the drug. Now, sometimes that does happen, and I always laugh when some of my colleagues that I work with that do the scrubbing and getting the patient ready and equipment. One time my friend Gary came in and said, "Chris, I think they brought the wrong patient into the room because this patient you told me was paralyzed and couldn't talk. This patient's sitting up and talking and walking and asking why we're doing this." So I walked into the room, and sure enough, the clot busting medication had solved that problem, and that's another case that I get to say went just great because I didn't have to do anything. But the reality is that those drugs don't work well in large vessel clots, and so that's when I get involved in the case. Those patients, I go in through the femoral artery with a small tube called a catheter, which is, I direct up into the affected blood vessel, try and get through the blockage safely. And once I'm through the blockage, I deploy a device that looks much like a stent that has mesh work to it. There's a couple of companies that make those devices, and Solitaire devices, one of them, and the Trevo device is the other. And there's also a device that I use that's like a vacuum cleaner, and I always tell people, if you've ever seen a crocodile jump out of the water and grab onto one of those wildebeests and start dragging it into the water, it kind of has that kind of effect, where the wildebeest is the clot, and you kind of suck onto the back of it and start dragging that clot out of the patient's body. And so there's a vacuum cleaner device made by a company called Penumbra, and these are all just different techniques and tools that are available, but at the end of the day, I'm a brain plumber. I'm unplugging a clogged drain, and it's very much like having a clog in your sink where the liquid Drano like the medications that we give, and hopefully that'll dissolve the clot. And if that doesn't, then I'm the rotor-rooter guy that comes in with different tools to get that sink unplugged, so to speak.
Mm-hmm. And some of those things we can actually control. We can control with diet and exercise some of the factors that lead to stroke.
Yeah, it's just really important to harp on the issue of prevention, because in stroke, an ounce of prevention really is worth a ton of cure. And so you want to stay fit, diet, exercise, keep trim, just like Chris. All right, you want to treat your hypertension, your diabetes. If you have atrial fibrillation, you need to take blood thinners. There's no amount of smoking that's good for you. And at 80% of all the risk that's wrapped up in stroke is embedded in those risk factors. So theoretically, we could prevent 80% of stroke if everybody would do those things. Now, there are certain genetic predispositions, and there are flukes of life and just weird things that happen to people. But I don't think any of us here wouldn't mind being put out of business if people just paid attention to those things.
We have our first phone call this evening. We're talking with Emil in Calgary. Hi, Emil.
Hi, how are you?
Very well, thank you. You have a question?
I'd like to ask one of the doctors there for their opinion of symptoms of a stroke. A few years ago, I was watching TV, and all of a sudden, my hands start shaking, especially my right hand, that I had to grab it with my left hand to stop it from trembling. And I noticed that I had a hard time walking, going upstairs, actually to my bedroom. And when I did go to my bedroom, I got into bed, and I stayed in bed for about 2 or 3 days, and I was really nauseated and bringing up and everything. And then when I went to see my doctor, I had to hang on to the walls because I just couldn't keep my balance. Then I asked my doctor if I had a stroke or whatever, and he said I didn't. But I've got atrial fibrillation, and I'm a 2 diabetic.
Dr. Wien?
Well, so in general, it's something that affects both sides of the body at the same time. Most often is not a stroke, but it certainly is possible that because of the atrial fibrillation, you send off more than one blood clot. And given the fact that you had a hard time walking, you're holding on to stuff, it's certainly worth investigating.
Mm-hmm. Nausea, is that common?
Yeah, so we talk about the carotid arteries in the front, we talk about the vertebral arteries in the back, and the kind of symptoms you're describing sound like something that might happen from the arteries in the back, and atrial fibrillation and clots from the heart are commonly causes of stroke in that area. Mm-hmm. So it's certainly worth investigating. I would wonder whether you were on Coumadin or a blood thinner at the time, and if that was therapeutic or not, and if you had any scans or not, and certainly worth checking that out so you get some preventative treatment going on.
All right. We have Carl here in Spokane. Hi, Carl.
Hi there.
Welcome. You have a question?
Yes, I do. I have had a pacemaker implemented approximately 10 years ago, and I've been on Coumadin ever since. My INR is very steady. I'm right between 2 and 3 where my physician wants me to be. But about 3-4 years ago, I changed over to Pradaxa for the reason of simplifying things. And I had stomach issues from it, so I had to get back over to Coumadin. And now I've been told that maybe I should consider Eliquis. The financial part is one consideration, but would it really give me additional help to prevent a stroke? That's my question.
Dr. Murphy?
You know, I think Eliquis has shown, they did a study looking at Eliquis versus warfarin, and that there was some benefit and risk reduction of stroke with Eliquis and lower hemorrhagic stroke, lower bleeding rates, you know, with Coumadin versus Eliquis. You know, it's a hard call to make. Eliquis is not inexpensive. It's hard to find insurance companies to accept it. You know, part of me says, God, if it's not broken, don't fix it. But, you know, I think you certainly need to be on some oral anticoagulant agent. It's worth a trial, but I think if you're tolerating the warfarin well, I don't know, perhaps less is more in that case. I don't know. Do you feel differently?
I think you can, if you can manage warfarin well and you can stay on it and adhere to it, and your INRs are good, you can watch your diet, the warfarin probably does a reasonably okay job, and the cost benefit is usually seen in populations of patients. Unfortunately, it doesn't help the individual person in terms of cost benefit ratios. But I would say warfarin seems like the better drug for him since he was well controlled on that.
Yeah.
Okay. We have Deidre in Calgary. Hi.
Hi. I take blood pressure pills. I'm 76. I think I've been taking them for probably about around 10 years. I exercise lots. My weight's fine. Am I still at risk for strokes?
Good question.
That's an excellent question. I think the answer to that question is yes, we're all at risk for stroke. Even Chris here, who's the pinnacle of health, we're all at risk for stroke. You can't reduce it to zero. But you're doing all the right stuff, and you're doing the best that anybody could possibly do, it sounds like, to minimize your risk.
Mm-hmm. Does the risk increase as we age?
It does.
It does.
And that's not a lot we can do about, unfortunately.
Some people try.
Yeah.
Yeah. Well, and we have an aging population, so we're going to start seeing more
we certainly
strokes.
Will. Absolutely.
Yeah, yeah. And
now, just one important thing is some of the antihypertensives, the blood pressure medicines, seem to also have neuroprotective effects, just like the statins do. They protect brain cells, so if you have a lower risk of having stroke, you have milder strokes, you recover better from the strokes if you're on those kind of medications. So it's not to the point where we can really say everybody we should put it in the drinking water or anything. But if you need those medicines, they do tend to protect brain cells and are very helpful. So stick with them.
And hypertension is a pretty prominent risk factor. So, I mean, and it's hard. You can't tell when your blood pressure's high. So, I think making sure you always have good control of that over the course of the years to follow, I think, is essential.
Okay. Yeah. We've talked a lot about how it is critical to get care quickly when you're having a stroke. It's important to get to the hospital right away to be seen by a neurologist, but that level of care often isn't available in small towns, and we do live in a rural area. Now, an innovative program is called Telestroke. It is changing that by connecting doctor to patient any time of the day or night.
When you're having a stroke, time matters.
We treat stroke like a golden hour. If you can get TPA within 1 hour, you've got a significant chance of decreasing disability and improving the chances of good recovery.
TPA is a drug used to treat the most common type of stroke. It works by dissolving blood clots. It's effective, but it needs to be used right away. It's also dangerous and requires the expertise of a neurologist. Someone like Dr. Cynthia Murphy, the stroke director at Providence Sacred Heart.
So, ma'am, do you have any history of stroke, family history of stroke?
When she's not in the hospital, Dr. Murphy is on call, ready to treat stroke patients across the region.
Sometimes I'm home, sometimes I'm pulled over the interstate.
Using a laptop computer, Dr. Murphy is able to connect with one of the 18 emergency rooms in Washington and Idaho, who are part of the Telestroke network.
Anywhere there's a Wi-Fi signal, you can beam in.
When Dr. Murphy beams in, she connects with a high-tech ER equipped with robotic cameras. It lets her talk with the patient, family, and of course the on-site doctor who's done the initial diagnosis.
I prefer to be there in person, but I'll take the robot any day.
A far cry from the days when Dr. Murphy would be on the phone. With the visual link that Telestroke provides, she's able to see her patients and really interact with them, allowing her to make a better assessment and diagnosis.
I mean, that just wouldn't have happened 3 years ago.
Whether it's treatment on-site, admission, or transfer, Telestroke brings 24-hour access to high-quality stroke care, saving time and lives.
Thanks. Bye. It's wonderful. It's tremendous.
Well, and the good news is there are 18 hospitals participating in Telestroke, and we have posted a map on our website that shows all of those locations. To see it, you can go to ksps.org and click on the Health Matters button. Dr. Murphy, how much of a difference has Telestroke made?
Oh, it's tremendous. It's, a third of our patients are coming now to Spokane through Telestroke, but, these are small regional hospitals, 15, 25 beds. That have, they're 150 miles away from Spokane, and to be able to deliver quality stroke care via telemedicine has been tremendous. The outcomes are huge. There is, and I don't know if I can give a shout out to Bonner's Ferry, but they had a case where they had a patient who was under 45, around 50 minutes TPA that we're able to send over here for intervention. And I think you actually took care of the patient. It was a left M2 revascularization where the vessel was reopened on the left hemisphere. It was tremendous. Without it, she would have been completely aphasic and been unable to speak and follow commands. So we're seeing more and more of these coming through in small regions. It's just outstanding. And the best part, I think, is because people want to stay. You know, I think a lot of people like their hometown, they like their region, and if you can give them the same quality of care, either without having to come into Spokane, and they can stay in Bonners Ferry and have the same quality of care, I think that's what they want. So I think you're seeing a lot more hospitals in the smaller regions getting a lot more interested in stroke. They're building their programs. It's just been an exciting time kind of statewide.
So this type of technology is just going to become such an integral part of what you do.
Oh, absolutely, without question. Yes, definitely.
And I think what's actually very interesting about that is the imaging piece to it is really helping patients stay at home, really, and or identify patients that need to come to us for large vessel occlusions. And so my partners with Inland Imaging, they are reading these imaging studies and helping the neurologists interpret the CT scans in a timely fashion to determine which patients have brain that's not dead already from the stroke, that is a large vessel clot that would benefit from coming to Spokane, and which patient doesn't have that condition and actually can get just as good treatment in their local facility with IV therapies, et cetera. And having said that, a lot of patients are transferred for higher level care at Sacred Heart, depending on the severity of their stroke, even if it isn't something we can open up. But they would still benefit from coming for higher level services, the rehabilitation services, things like that. But the imaging piece that Inland Imaging is providing, and my partners are providing, is I think a real nice supplement or augmentation of this whole telestroke program.
You can't do it without imaging. You're absolutely right. You can't.
We know that stroke is one of the #1 killers, but it is the #1 cause of disability, Dr. Stevenson. And again, that's where you come in at St. Luke's. What are we talking about as far as rehabbing? What do you see in patients? Paralysis, speech impairment, that sort of thing. And how difficult is it to rehab from that?
Well, like I said before, with the different strokes for different folks, it really depends on what part of the brain was affected to what we see. The left hemisphere is going to cause problems for most people with language and right body paralysis. The opposite side would have left paralysis, but also affects your visual spatial functioning, and people may not really even be aware that they had a stroke. Strokes in the back part can affect your overall coordination and balance, and nausea and vision problems. Brainstem strokes can act almost like a spinal cord injury, where they can have weakness on both sides. If it's bilateral, they can have swallowing problems, and there's a whole variety of different things we can see with that.
A lot of frustration, I imagine, for patients when they start this process.
Yeah, I've never had anybody come in and say, I am so happy I had a stroke. This is the best thing ever. So particularly the language part is really frustrating for people when they can't get across what they want to say. And sometimes people don't understand that they're not making sense, and they think everyone around them has gone crazy because it doesn't make any sense with them.
So it can be quite a long process as well.
Right. So I always tell people, you see your most recovery for at least the first 6 months. So at St. Luke's, like in 2015, we had 476 stroke patients with an average length of stay of about 2 weeks. So we're really just seeing them for a little snippet of that early recovery to get them going in the right pathway. But they have a lot of work to do for several months.
We have another phone call from Cindy here in Spokane. Hi, Cindy. Are you there? Well, we may have lost. Okay, we lost Cindy. Again, we do welcome your phone calls and emails on stroke this evening. Dr. Ween, you briefly mentioned TIA, or what we commonly call a mini stroke. Is that correct?
Yeah.
Same thing?
I hate the term mini stroke because it means so many different things to different people. So a transient ischemic attack is a stroke that goes away within, by definition, 24 hours, but on average 30 minutes. It is a warning sign of stroke, so it means that something's going on. You want to make sure that your carotid arteries are clean, so you need to have those imaged and looked at. You want to make sure your heart is okay. Hemorrhages generally don't cause TIAs so much, but there is a number of tests you need to have done, and there are very effective treatments. At Deaconess, we pride ourselves that we take them very seriously. Somebody comes in with TIA or minor stroke, we actually open up the carotid artery within 3 days. because that's when the highest risk of recurrence of stroke occurs in those situations. So we want to be aggressive with those. I like to say in a statewide situation, we spend a lot of money on hyperacute stroke treatment once the brain is damaged, but TIAs kind of get lost on the wayside. But the brain has recovered completely, so you got way more brain tissue to save. So TIAs need to be taken very seriously.
And people can have sometimes several.
Yes, and there's something called crescendo TIA, which is a buildup of the TIA symptoms that get more and more frequent. That's very dangerous. So you need to really go see your doctor quickly for that, or go to the emergency room if you have one and get it taken care of right away.
Another term we are hearing, Dr. Murphy, is wake-up stroke. What is a wake-up stroke?
Well, wake-up stroke is folks that go to bed, say you go to bed at 10 o'clock, they wake up at 4 in the morning, and they can't move the left side. And so by the time they come to the emergency room, say it's 5 or 6 a.m. and now they're 4.5 hours outside treatment window. And so there's a good number of high percentage of strokes that do happen in the middle of the night. They wake up with symptoms. And it's a very exciting time to decide on treatment and how can you proceed treatment for folks that wake up strokes. There's active trials that are enrolling right now, trying to see, well, can you TPA someone outside that treatment window if they're a wake-up stroke? Can you intervene on them endovascularly if they're a wake-up stroke? So it's becoming a very exciting time. I think that the next kind of frontier and we're waiting for in stroke is to how do we manage these folks, because there's a lot of them, and it would bring a huge amount of support.
And there's some really very exciting imaging capabilities we got now that can distinguish between what's brain that has just decreased blood flow but not a fixed stroke, and how much brain is actually a fixed stroke. And you can wake up with your brain at risk. We had one case at Deaconess just this morning. That's why I got these big bags under my eyes. Where there was a lot of brain that was at risk for damage, but not a big core stroke. So we were able to suck the clot out of the carotid artery and restore blood flow quickly. And a lot of the trials that Dr. Murphy is referring to is about how you use those kind of perfusion blood flow studies to help direct your care, even outside the 6-hour time window. Because we know that the 3.5 hour, the 4.5 hour, the 6-hour time windows, they're all statistical things, and it's all a question of the population of patients of benefiting more than you hurt. There's always going to be some people at the top of that curve that you could possibly benefit, and those are the ones you want to identify with these fancy imaging modalities that we're using now.
Dr. Zylik, you come in on this conversation as well.
Yeah, I think the part for me that's most interesting, and I just want to expound a little bit about, is what is a time window and why is a wake-up stroke? What does that mean exactly? Well, a time window in our lingo means when were you last seen well? And so if you were last seen well, we're all here together. Well, we all know we're, by some definition, well at this point. And if all of a sudden I were to start having symptoms, you would know precisely, well, Chris started he couldn't talk and slumped over in his chair right at 7:33. Well, that's my time onset of my symptoms. And so within a 4-hour window, I can still receive IV TPA as the FDA-approved standard therapy, but that's all from the time of onset. So the wake-up stroke, just to clarify a little bit more, to talk about a little bit further, the patient went to bed at 10 at night, let's say. I fell asleep watching a TV show, and they were last seen well at 10 o'clock. Well, if their stroke happened at 10 to 3, but no one knows that, right? They don't know that that stroke happened at that time. So they're referenced in our medical jargon and funneling and triaging. Well, they were last seen well at 10 at night. But in fact, they may have not had any stroke at all till 4 in the morning. But we said, well, the last time you saw well was 10 o'clock at night. Therefore, you can't get IV TPA. So where I hope we can get to is the point where the imaging, the salvageable brain, really determines whether a patient is a candidate for treatment, and time windows are really out the window. Because even if a patient is 10 hours out, but they still have salvageable brain on their imaging, then I don't really care that they're 10 hours out. Why should I not try and save that brain? You can make the argument, well, the brain that's been damaged by the stroke is at a higher risk if I unplug the artery, that the brain that is damaged is more friable or more at risk for restored blood flow to cause bleeding, so that they're higher risk for complication. But my argument back has always been, I know that if we don't treat that patient, that large stroke, they have a really high risk of doing really poorly. They're going to never talk or move the right side of their body or potentially die. a left MCA stroke occlusion, untreated, has in some studies between a 50 and a 70% chance of death or major disability. A stroke that's in your posterior circulation that Dr. Wien was talking about, if that artery remains plugged, they have over an 80% chance of dying if that artery doesn't open up. And so when you're looking at time windows, I think we're really limited in excluding patients that can be treated by these life-saving therapies because of what we had at the time when these studies were created was a time window of time of onset. And these newer studies that Dr. Wien and Dr. Murphy are referencing, I hope are going to get us completely away from a time paradigm and totally look at brain viability based on perfusion and CT imaging, and these are MRIs and CT scans that inland imaging performs to help determine which patient is a candidate who has salvageable brain and how can we best triage and treat those patients. So hopefully within 10 years from now, you'll have us back and we'll be talking not about time windows and treatment windows, but really talking about salvageable brain tissue that we can all be very enthusiastic and help a lot more patients.
Yeah, that's very exciting. Let's take another phone call. We have Wanda in BC. Hi, Wanda. Thank you for waiting.
Yes, good evening. I wanted to ask a question. I have a mechanical heart valve. Am I any higher risk for a stroke because of that?
I would say yes, without anticoagulation. I assume you're on anticoagulation?
Yes, ma'am. I'm on Coumadin.
Yeah, Coumadin. I think making sure that level is always therapeutic. I think lower levels on mechanical valves. The problem with mechanical valves is that it has a tendency to form clots on the valve. So we anticoagulate folks with mechanical valves. So we try to prevent formation of clots that form on the valves to the heart. Clot goes to the brain. So that's our rationale. So it's always essential to be anticoagulated with a mechanical valve.
Okay.
Does that answer your question?
So yeah, I just didn't know if it would change the ratio as if I didn't have a mechanical heart valve.
Your risk is higher.
Okay.
Yeah.
All right. Wanda, thank you for your phone call. We're hearing some very specialized questions this evening, very particular to the cases that we're hearing. Let's talk about the general population, again, an aging population. What can we do as far as nutrition and exercise? What do you recommend? Are we looking at a heart-healthy diet the same way that we look at preventing stroke?
Well, actually, I think most of the research is pointing towards the Mediterranean diet as being the thing. Lots of vegetables, fruits, olive oil. There was one research trial looking at carotid stenosis or blockage of carotids that had their patients drink a quart of olive oil a week.
Oh my.
That's a lot of olive oil to go through, but they actually could measure regression or shrinkage of that plaque in the carotid artery with the olive oil. So, you know, the American diet is all French fries and hamburgers and steaks and fatty stuff, so away from that and more towards the olive oils and the green leafy vegetables, the lean meats and fish and so forth, and smaller portions.
And exercise, what do you recommend?
10,000 steps every day.
Doing something?
Yeah, that's what it says. You know, I have this watch that reminds me to move, and it's already gone off once while we were sitting here. So if you think of how long we've been sitting here talking, all of us should have been up and made a little lap around the room. And so those are things that are hard to do when we're all doing our job and our daily work. And, you know, there's lots of innovative ways to be moving around at work or to motivate yourself, and all of these Fitbits and things like that I think are great reminders for people just to do simple things like take the stairs at work instead of an elevator. And if you did that every day and multiply that by multiple steps and days, you know, there's simple things you can do if you can't make it to the gym. You know, I have friends back home that call me and, well, what do you do here? What do you do there? It's like, well, you can drop down and give me 10, you know. So, and there it goes again, move. So, yeah, so it didn't
How
like that.
How often does that go off?
Well, if I don't move, it goes off again. So it gives me a couple little shots there.
Oh, that's a nice little reminder. Let's take a phone call from Rene here in Spokane. Hi, Rene.
Hi.
Do you have a question?
I have a couple of short ones, but the first one is several years ago in a community, small community in Oregon, my husband and I went to take my mother to dinner, and she was sitting on the floor and had symptoms of a stroke. That is, she would respond with only common phrases. She didn't initiate speech. she couldn't really tell us much of anything. Because of experience with my dad, who had had a stroke and had been aphasic and eventually could talk a little, right away I picked up on it. I also knew that she'd had some TIAs, and we got her to the community hospital, and I told them she was having a stroke. They totally ignored me because her pupils were level. I want to know, what can you say to medical personnel to get them to listen to you if someone's having a stroke and the symptoms don't quite match in their mind?
Come in on an ambulance. Come in on a gurney.
Well, we didn't have any choice.
I know. That's unfortunate, but if you come in on an ambulance on a gurney and the family's saying stroke, the heat is on. I mean, the level of attention is just greater. In terms of the pupils being symmetrical, I mean, that's neither here nor there, I don't think, for the kind of symptoms your mom is having.
You know, and I think stroke is becoming, even in the last, 5, 10, 20 years, more, even among the medical communities that aren't, I'm a neurologist, this is what I do, but for a lot of folks in the ER setting are learning more signs and symptoms of stroke itself. I think it's not only the public at large, but it's also the medical community also understanding the signs and symptoms of what to look for. I'm sorry that happened. I agree with you. I think if you had an ambulance, it's a lot easier, but because they do descend upon you a little faster. Mm-hmm. Yeah.
What happened? I mean, even if a patient comes into the emergency room without a family member who, may be recognizing the signs of stroke, but doctors are reacting more quickly. They're seeing the signs quicker. Is that correct? I mean, this process is happening faster than we've ever seen it happen.
Well, I think for me, all of this is motivated by our treatments that have been relatively new over the last, say, 10 years, so to speak, and particularly so with more recent studies coming out showing that we can actually prevent these large strokes from progressing to be permanent deficits, that the whole medical community is much more involved and interested. That's how telestroke is popping up. That's why people really want to be a part of giving IV-TPA, because there are immediate treatments that can have these massive benefits. I can tell you my enthusiasm for my job is so incredibly high, because when you take a patient who's paralyzed and can't speak, and then you remove the blood clot, and the next day they're back to their normal self, there's nothing that I do that gives that sort of satisfaction. And so when the whole medical community gets behind that event, because although I'm the one removing the blood clot, there was the efforts of everyone here for sure, in addition to the ambulance people, the medical personnel, everybody is involved in having those successes and the rehabilitation of the patient afterwards, getting them back up to their top level that they can get. So the whole medical community is really, I think, excited about these kinds of outcomes, whereas truthfully, 10 years ago, if you had a stroke, there wasn't anything to do. And so there weren't these therapies and there wasn't a way to reverse it. So, this has all been a sort of a big snowball that's starting to gain that critical momentum and starting to come crashing down the hill, and it's really exciting.
We have an email this evening from Candace who says, what role might genetics play in having a stroke?
It has a very complicated role. Some people have genetically determined types of strokes. I mean, they're inherited conditions. There's probably genetic predispositions. Hypertension, heart disease are probably a genetic factor and all that, in addition to an environmental factor. It's not a modifiable thing, so you have to focus on the things that you can modify. I don't think we've gotten to a point where we do genetic counseling for having children and stuff yet, based on some of these diseases. But there's certainly a role, and if you have lots of family members who have stroke, should possibly be looked at for some of the genetic causes for that. There are tests that you can do for that.
Mm-hmm. Dr. Stevenson, how big of a role can family and friends play in recovery?
Well, it's really important because they're a huge motivator for patients as they're going through their therapy, and then a support for when they leave inpatient rehab. It's the rare stroke patient that has such a good recovery that they actually can go home totally alone. Most people need someone to help them out, or they can't drive for a while, or something like that. So it's very important.
Mm-hmm. And what can you tell them about that process when they're trying to help someone in their family who's gone through it?
If they're there on admission, we explain what the whole rehab process is, invite them to come to therapies. And then as they get closer to discharge, we actually schedule formal training with them. They can also be very supportive in helping the patient stop smoking and modify the risk factors. So like when I have a son of a patient there, you know, I said, your family history just got worse because your mom just had a stroke. So that usually gets their attention for maybe making some changes themselves and things. But, you know,
if a patient is able, how important is maybe having a support group to go through this?
We have them start in like some support group activities while they're an inpatient, and they can continue that as an outpatient. You know, some patients aren't really into that kind of thing, but I think for other folks it's very helpful.
To be able to bounce, you know, you're not alone,
right,
sort of thing. Let's take another phone call from John here in Spokane. Hi, John.
Hello.
You have a question?
Yes, it has twofold. I am and my wife were both Vietnam vets exposed to Agent Orange. My wife died of a cerebral hemorrhage this last March, and I myself have a pacemaker and have had a blockage. I was told I did not have ischemic heart disease, but stroke has always been in my mind for both of us. And what are your feelings about exposure to the Agent Orange having to do with strokes?
I started my training in Boston and spent a lot of, as Dr. Murphy also did, spent a lot of time at the VA, and so we heard a lot about Agent Orange. There's so much controversy surrounding that. I don't know if I can wade into that controversy with any confidence.
I'm not familiar with the association yet with stroke and Agent Orange.
I'm sorry.
It is a controversy, yeah, you're right.
Yeah. There are probably other risk factors and things that go along with your situation that are more important than the Agent Orange exposure, I would suspect. But that gets to be a complicated thing. And I think seeing a stroke prevention clinic where they can actually help you sort some of those factors out would be a helpful thing for you.
Yeah.
Talk about the relationship with AFib.
So atrial fibrillation is irregular heartbeat, and so folks with AFib and other vascular risk factors are at higher risk of stroke, and sometimes it can be up as high as 12-15% a year without any treatment. So there's treatment options of anticoagulant or therapy. There's the warfarin, which is the traditional oral anticoagulant, and then there's we call them NOACs, novel anticoagulants. They're newer agents that have been out, like that gentleman called earlier about Eliquis. There's Pradaxa. There's a number of new agents out, and essentially, the purpose of anticoagulation in the setting of AFib is to lower. It can lower risk reduction by 7%. So you take that 12% risk, and you drop that down by 7%, and that's a 3 to 4% risk yearly of having a stroke. So there's clearly benefits of anticoagulation. I had gone to a lecture the other day about AFib and from a cardiologist, and they were just saying it is still an undertreated population, that we're not addressing all the folks with AFib that are at risk for stroke, and the problem with AFib and stroke, I'll also say, is that they're the bad strokes. They're the ones with the giant clots. They're the ones that we have to send to Chris to retrieve. A lot of them tend to be a little bit worse than in AFib than in other types. So what we did discover was just that it's still an undertreated type disease.
Another thing to keep in mind about AFib is it can come and go. So you can have periods of time where you don't have it, and there are periods where you do have it. And some exciting studies about longer-term monitoring of your heart looks at monitoring people up to 2 years, and at which point you have an 80% chance of picking up this intermittent atrial fibrillation. So there's some steps that you can go through to try to detect whether they have atrial fibrillation or not, but sometimes it's very difficult to identify it.
Okay.
And we occasionally catch it on the inpatient rehab unit where, suddenly a nurse says, hey, their heart rate's really fast and irregular, and that hadn't been seen in acute care, even on a monitor, and you can say, aha, we can maybe tell you why you had your stroke.
Yeah, but it can present just sort of almost out of the blue like that.
Right, and frequently with people that have strokes with atrial fibrillation, it seems like it's the first onset of atrial fib or the first diagnosis with it that they have that stroke. They didn't have that heart rate be fast before.
Well, you can't feel it. You can't. Right. Sometimes you can, but for the most part you can't. So someone would not know if they were in AFib. So it's we look for. It's one of the things we look for, both in the acute setting, the loop recorders in the outpatient setting, and really, Holter monitors we use to be able to sit there and detect AFib, which it's such a significant risk factor.
Okay, a few minutes to go. I want to see if we can get a few more phone calls in. Tom from Leavenworth. Hi, Tom. Thank you for waiting.
Oh, gosh, thank you guys for having this conversation. It's fantastic. My question is, I had a massive stroke about 3 months ago, and I was lucky enough that my wife knew exactly what it was and got me an ambulance and got me to the care, and they did a fabulous job. And I'm, as far as the neurologist said, one of the miracle childs. But in getting back to work and doing everything, and no real problems to speak of, that I'm very, very, very lucky. But my problem now is that I used to be such a happy-go-lucky, good guy, and I have a real tough time with patience with my wife, and kind of being rude and short and curt with her over things that I would never ever have thought to do anything like that before about.
Dr. Stevenson, do you often see that?
Yeah, sometimes you can have some personality changes or adjustment to the stroke. You know, that's one reason we use rehab psychology a lot, to sort that out when that's the case and help patients and their families kind of learn how to understand what's going on with that. It, you know, could be due to the stroke residual that you don't see much else left.
Would you recommend that he talk to someone?
Yeah.
Find that help?
Post-stroke depression is also very common, and antidepressants are oftentimes very helpful, not necessarily forever, but at least for a short period of time. But sorting out what is a residual from maybe some residual brain injury from the stroke and what is a post-stroke depression can help with the management and treatment for that. And there are a lot of good treatments for that now.
Okay. We have Bob calling from George. Hi, Bob.
Hello.
Thank you for waiting.
Thank you. My question is, I guess, well, I'm going to get a little choked up here. My girlfriend of 5 years had 3 major strokes last year, and she had one got to the hospital, and then she had 2 more during her care at the hospital. And she actually came through it pretty well with a little bit of rehab and this and that. But since that time, I know for a fact that she keeps having what they guess they call mini strokes. I mean, and she's almost showing signs these days of Parkinson's disease, where her nerves, she limps on the right side a lot more. You know, it was a right side stroke, and you know, I guess it has more to do with stress related. I'm not sure, but I'm having a hell of a time to get her to go to the doctor. She has high cholesterol, which we've tried to work on with the diet, the 2 of us, because I'm a candidate for a heart attack, and so we're trying to eat better. But what could she do holistically? I guess I'm trying to say without Coumadin or the other blood thinners. I know you guys are actually, you know, prescribers of prescribed medicines, but what could I get her to do, because she's more of a holistic healer, to help with the blood thinner, the blood thinning. You mentioned the Mediterranean diet. We tried to do the vegetables and fruits and things, but I'm just concerned.
Yeah.
Well, Bob, thank you for your call, and we can hear your frustration and your concern. Is there anything he can do to help with holistic medicine?
Well, the problem for us with holistic medicine is there's not a lot of research behind it, and so we can't make firm recommendations one way or the other. It certainly sounds like you're trying to do all the important and things that you can do in terms of diet and exercise. A point comes, though, in some of these situations where these things just keep happening, that you do need to take medications. And there is no holistic way, because the impact of that holistic treatment isn't necessarily that powerful. I'd be suspicious that you may have tiny little strokes that are occurring, causing a Parkinson's-like syndrome. Oftentimes, aspirin-like medicines can really help with that, making sure your blood pressure is in good control. Any diabetes is in good control, and exercise, just like you're doing. I just have to say, if your doctor isn't listening to you, find another one, or beat him up until he listens.
Dr. Murphy, are you a fan of any supplements when it comes to preventing stroke?
I'm thinking. You know, I don't see it that much on the acute side. I wish. I don't know if you prescribe any on the outpatient side for prevention? Niacin, coenzyme 10. I don't use them much in terms of the inpatient setting for supplements. I think and again, I'd like to see some evidence of the holistic approach for stroke prevention. I am sort of a fan of of the current FDA recommendations.
What about an aspirin, baby aspirin?
Well, if nothing else, then I certainly would recommend that.
And there's been a bit of back and forth on that as well, women as well, because we had heard men yes, women no. Where are we at with aspirin and women?
Again, sometimes the effect sizes in the research is so small that it's hard to say which is best for whom. Just looking at the biochemistry and the physiology of it, it wouldn't make a whole lot of difference. So a baby aspirin at least is what I recommend for this particular woman.
Okay. We are getting close to the end of the show. I want to get some final thoughts, some final bits of advice for our viewers on stroke. And Dr. Zylak, let's start with you.
You know, I'm obviously biased for people having large strokes that I can help them with. And I'll just tell you that the sooner you can call 911 if you see someone you love having trouble, the sooner they're going to get the help they need to prevent a major stroke. So call 911 if you think you're having a stroke.
Okay, and Dr. Wien?
I think it's very exciting to be here in Spokane. We're in a large and growing community. We got 2 good stroke centers now at Deaconess and Sacred Heart. We're building our capacity. We got whiz-bang interventions that we do at both institutions. We have imaging that really sorts things out in great detail. We got great rehabilitation. We have a system of care. If we can just put all these pieces together, coordinate it, we can really serve our community very well. And I look forward to working with all my colleagues in town to see that happen, because the population is getting older. We're going to see more of this. It's not going to go away, no matter how holistic and how healthy we are. It's going to keep happening. Having the capacity, having the expertise in town, really working to make it work well for the population. That's very exciting.
Dr. Murphy?
I agree with you. I think Spokane's gotten very exciting at stroke care, both at our institutions, certainly at St. Luke's, what you're doing in recovery, and in imaging, how they've kind of transformed providing us imaging. I think for folks out there, I think just to know that, you know, it's not the end of the road. You know, for some people, a very small segment of people don't always do well, but many do have recovery. They can overcome what's facing them. They can work towards prevention. We've seen so much exciting change in the last 10, 15 years, and I think, you know, both from the public at large and from us as medical providers, you know, that trying to bring families together, establish independence, bring back function and quality of life and what defines that. So it's still, I think, going to be an exciting time in stroke care.
Very good. Well, we have run short on time, but I want to thank all of you for being here. And that's going to do it for this edition of Health Matters. Our thanks to everyone who called in and emailed a question, and a big thank you to our panel for being here and sharing their expertise. Be sure to join us on October 20th when our topic will be lung health. I'm Teresa Lukens. Have a good night.
Health Matters is made possible by our viewers, the friends of KSPS, and by Providence Healthcare.
My name is Beth Perez, and I am a registered nurse, and I work at Holy Family Hospital on the labor and delivery unit. I'm about to have my second child, and I chose Providence because I love and trust the people that I work with, and why wouldn't I seek care from people that I love and trust?
I'm Dr. Andrew Boulay, and when my wife had a cardiac arrest, I chose Providence because I knew that everything we needed for her complex care was available, from the emergency room to radiology to the nursing staff to the specialists we needed for her care.